Hello everyone and welcome. My name is Neve, Research Assistant at the Australian and New Zealand Hip Fracture Registry. Before we start, I would like to acknowledge the traditional custodians of the land we live and work on and pay my respects to elders past, present and emerging. Today we will be answering some of the clinical questions from the recent Australian HIPFest. And to join me today we have Professor Jackie Close, geriatrician and co-chair of the registry, Professor Ian Harris, orthopaedic surgeon and co-chair of the registry, Dr. Hannah Seymour, geriatrician from Fiona Stanley Hospital in Western Australia, and Sean McManus, anaesthetist from the Mater Hospital in Queensland. Thank you everyone for joining me. So let's begin with the topic of anticoagulation and surgery. We had a lot of questions come through about renal function and direct oral anticoagulation. So for a patient on a DOAC, the first question is, how does renal function impact the decision for surgery?
Well, from my point of view, particularly the ones that have some renal excretions, apixaban, I guess, is the number one, that would make you consider how long those two half-lives would be. And if you're lucky enough to work in a place that does levels, if you had significant renal function, you probably would be thinking about doing a level. Having said that, literature, again and again is showing that a delay of two half-lives and proceeding, even if there's impaired renal function, the literature I've seen doesn't show that there's a greatly increased risk of bleeding. And as we've discussed previously, hip fracture population is unique and those delays are not without consequence. So if you're really worried, try and find somewhere we can do a level, I guess would be the answer I would give as an anaesthetist.
I think, Neve, the important thing with lots of these questions is that everything is a risk-benefit discussion in that individual. And so you can argue anything is appropriate if you've thought about it, you've documented your reasoning, and you've had a conversation with the patient and their carer. And I think everything in that situation is then a risk-benefit discussion about what's the best thing to do given the situation.
So for people looking for more informational guidelines on the use of anticoagulation and timing of surgery, what resources would you recommend?
So the UK guideline is very useful. I've read it again recently. And at the moment, I think that is the most contemporary guidance to use. We can put the link on the website, and I think that would be really useful. There's an appendix, which is the most useful bit for DOACs, that essentially emphasizes everything that we've just said. And we are looking at trying to develop something that is more tailored to the Australia and New Zealand setting in the next 6 to 12 months, which again will then circulate. But I think for the moment, the UK advice is probably the best one to use.
Just for clarity then, that's the Association of Anaesthetists of Great Britain and Ireland, and they produced a guideline in September of last year, and supplement one of that document is a very nice document, really taking you through the issues of managing anticoagulation in the perioperative setting for hip fracture care, and interestingly takes the perspective of both the surgical procedure itself, but also from an anaesthetic perspective. I think sometimes we forget that for neuraxial anesthesia, there are some requirements from an anaesthetist perspective. So it's not just the surgical procedure itself, it is the anesthetic as well, and there are implications. But it's a very nice document and is something that we will almost certainly use to try and provide something for ANZ HFR followers to manage anticoagulation in Australia and New Zealand.
We might move on to the next topic and keep firing through. And this next question is a little bit tricky because they've only asked for one aspect of care that you think is key in preventing delirium and is often neglected. Can we pick one?
There's no one, Neve, except I would suggest that if all members of the multidisciplinary team learned to respect the brain as an organ, I think we would all be better off. And it's not just geriatricians screening for people who might be at risk of delirium. Every member of the team has a role in terms of looking after somebody's brain health. If somebody's got ECG changes, there's panic. If somebody's creatinine has gone off, there's panic. We do things. If somebody's become confused after surgery, don't bat an eyelid often. It's the most common complication.
Just echoing those points about it not being one single thing, because we published a study from Liverpool Hospital where we looked at a bundle of care. So that included everything from the emergency department, nerve blocks, the drugs used in anesthesia, avoiding drugs post-operatively that are associated with delirium. And we could decrease delirium, but it's not just one thing, it's lots of things.
The one thing I would say, and just echoing what Jackie says, is we consider it a surgical emergency when someone is very agitated and awaiting a hip fracture surgery. Those people who are the very small group who are incredibly agitated pre-op do the best with early operation. And I think that is really important for people to take home as well. Occasionally you get people say, oh, we delay them because I've got delirium. It's like, no, just take them to theatre. And it makes people look so much better. We had a 98-year-old lady who illustrated it beautifully last week. Chinese, didn't speak English, looked absolutely awful in a bed, delirious, had her operation, and the next day got up and walked 20 meters down the corridor.
That's pretty incredible. We also have some questions about the associated risks of delirium with indwelling catheters or IDCs, and asking your opinion on whether you think it's indicated to insert them preoperatively, and are there any increases in adverse events if they're not inserted?
So we've all experienced consequences of precipitous removal of indwelling catheters with inflated balloons. It happens. You could question as to whether you actually really need the catheter in the first place. And I know, well, Hannah will comment, I'm sure, that there are hospitals over in WA that don't even use catheters. I think culturally it's a big change to get people away from the idea that we need catheters. Men can certainly pee into bottles with a hip fracture preoperatively. Harder to get women onto a bedpan unless they've had a good fib. And then if you want to be, or you want to have robust measurement of input and output in the perioperative phase, then an IDC, of course, is useful. But anybody that is delirious, number one, think twice as to whether you really want to put it in. And if you do put it in, take it out as quickly as possible before they do it for you.
That was the next question. So when do you recommend taking them out? I know there's lots of different practices in lots of different places.
I do it day after surgery. There's all this, I think it's myth really about leaving catheters in until people open their bowels. I don't know what evidence there is for that.
I don't know where it came from. I've even looked for it and couldn't find it.
Yeah, I mean, I'd echo that. I think the anaesthetic community is moving towards things like arterial lines for measuring blood pressure, and not really worrying about urine output as a measure intraoperatively. So there's no particular reason that I can think of that we would be keen to have an IDC for that perioperative journey in theatre. And particularly now we're not using as much fluid as we used to previously. We're using a bit of vasopressor, so there's not really an urgent need to put a catheter in somebody having hip fracture repair.
You can make an argument for anything. Again, in this setting, it's about 50-50. Denise Glennon at Charlie's is absolutely passionate that you don't need catheters. We've actually struggled to engage our surgeons in having that conversation. The nurses on the ward believe that they have to roll people anyway. It makes no difference to pain whether you are using a bedpan or not. Because of pressure care resources, they have to actually roll people anyway. But I think the message is, again, agree something locally, don't have local variation, agree what you're going to do and stick to it. And so I think that way you at least get consistency, and then if you change it, you change it consistently.
So the next topic we've got is on pain management, and looking at preoperative care. In what circumstances would you say a fascia iliaca block or a fib is not appropriate for a patient presenting with a hip fracture, ignoring things like allergy, well, not ignoring, but passing things like allergy or patient not consenting? Are there any other circumstances you could think of?
I think that's the beautiful thing about the fascia iliaca block is that it's such a low risk block that in a hospital I worked at, our acute pain nurse was putting the blocks in. So unless there's a dirty, great big infection exactly where you want to put the needle in, I can't think of any other particular contraindication for a fascia iliaca block.
And we've got up to 98-99% of people getting a nerve block. I think there is really, the only time that we consider it is if someone's come in with a chronic hip fracture, those very rare people who've walked on it for a little while, in which case you'd argue maybe you don't, but that's the only situation.
And what about moving to intraoperative care? Is there much research or much thought about what anaesthetic agents are more likely to cause a post-op delirium?
This is a source of perennial papers around. So, I was involved in an international consensus from the Analgesia community a few years ago. We published, and the consensus was no. I've just re-looked at it. As we know, lack of formal randomized control studies is very hard to do. Look, it makes intuitive sense to me that spinal with no sedation you would think would be better, and all of us want to believe that, but it's very hard to see the solid evidence to do that. So you can defend, as Hannah said, if that's best in your hands, a general anaesthetic. What I would say passionately is please consider not using benzodiazepines, and consider in this day and age, you can reverse muscle relaxants with sugammatic, so you can avoid atropine and neostigmine. All of those other, cyclizine, all those other anti-nausea sort of other drugs that you might routinely give to other patients, just think really hard about it. So a short-acting general anaesthetic, sevoflurane propofol with a nerve block, or a spinal. And if you do need to sedate with a spinal, I would strongly advocate for low-dose propofol infusions that can be switched off at the end. That would be my belief.
What are your thoughts about pain management after surgery for a patient who's high risk of delirium with or without dementia? Would you recommend a regular analgesia or just PRN?
Well, I'll defer to my colleagues who see a lot more post-operative patients than I do. But realistically, if you've got good surgical fixation, some local anaesthesia infiltration, perhaps a redo of the fascial arca block at surgery, and then some paracetamol, you can argue that your opioid requirement should theoretically be less after surgery than it is beforehand. But if you do need to use it, obviously the obvious things are minimise opiates, think carefully about nonthrottles in older patients, and the other agents, case by case basis, I suppose.
I think, again, it's about respecting that this is a multidisciplinary approach and making sure your nursing staff on your ward are really knowledgeable about what doses of opiate to give. We try and stick first line with one opiate. We choose Targin and Endone. We go with the lowest dose to begin with and start really slowly. The nurses are very good at giving the lowest dose because they know that drug really well. So I think there is benefit for your whole team on the ward to having a protocol that's agreed locally that people understand, rather than everybody getting different drugs. And I think challenging ourselves as geriatricians to use more non-steroidals is really important. And we've tried really hard to increase the use of those, particularly post-operatively on selected patients when you're really confident that their kidneys are okay. We would use those first line for some patients. I think it's also that knowledge about what sort of procedure people have had. So a hemi, for example, very comfortable not giving people much opiate. But if you've had a big nail put in, you've had a nasty intertrochanteric fracture, you're going to really struggle to get up and participate in physio without some analgesia on board. So I think, again, that team working together and understanding from the physios and the nurses how much pain people are in is really important in making those decisions.
The other thing that's worth noting is in people, so a lot of people with dementia and delirium, they're perfectly capable of telling you whether they're in pain or not, but there are very definitely a group who do not have the cognitive reserves to be able to tell you whether they've got pain or not. And so you need to make sure that you have got pain scales that are fit for purpose. So your aggregated FACES works for most people, but not for people with a severe dementia. So you need to think about something like the Abbey Pain Scale or the Pain Ad, where you then are reliant on nurses assessing patients to look for physiological signs that people are in pain and then make sure you give them analgesia. They are a relatively small group of individuals who don't have the ability to tell you they're in pain, but there are other mechanisms for being able to establish if they're in pain or not.
You mentioned the use of NSAIDs, and we did have quite a few questions come through about COXIB's use post-operatively. Do you use these, or for what duration? Yeah. And do you include PPI coverage, or what do you do?
So I think, good questions. And I think we try and use celecoxib. We try and pick one drug and stick with it. So we use celecoxib 100 BD, so slightly lower doses than other people might use for younger patients. And we don't routinely provide PPI cover, and we generally give it for 7 days.
My practice is changing. So I am using celecoxib more now. I think for a long time, geriatric medicine has been averse to the use of non-steroidals because of the risk of GI bleeding and renal impairment. But actually that means that we're giving out more opiates. Actually, but then we cause more side effects that are related to the brain. And the arthroplasty world, so for elective surgery, they use multimodal analgesia. The anaesthetists have it written up all the time. So my thinking has very definitely changed over the last couple of years. And there is a study that shows that intravenous paracoxib perioperatively reduces the chances of a post-op delirium. So I'm very definitely changing practice.
And I guess I would pitch in an understanding that the prostaglandin-mediated mechanism for renal failure with nonthrottles is in the context of a stress response. So if you've got your patient comfortable, reasonably well hydrated post-operatively, so they're not in an acute stress response, you're less likely to get into trouble than you are giving to somebody who's agitated, septic, unwell. So nonthrottles got a bad name, particularly in ICU, because our patients were very sick and unwell. But if they're just stabilised getting nonsteroidals and having their renal function monitored, I agree that can, compared to giving them opiates, is a reasonable sort of conversation to have with the team.
How long would you consider for something like a long-acting analgesia, giving that to a patient post-operatively?
Are you talking long-acting opioids, or?
Yeah, sorry, a long-acting opioid.
So, the broader anaesthetic community has been considering the fact that there are consequences to long-acting opioids being prescribed. Once again, they're appropriate for a short period of time, but I would suggest no more than 2 to 3 days, and be very mindful about sending patients home on long-acting opioids. We need to work hard to not have that as a routine discharge prescription.
I think the reality is that we know that a large portion of our hip fracture patients go to rehab wards, and we know, I quite often follow my patients up who I have for a very, very short period of time, and those that go to rehab, they generally get their opiates escalated in order to try and increase their mobility. So I think, this group of patients are different to an elective group where you're expecting people to go home in the vast majority within 2 or 3 days. And while you're in hospital, if you need those to mobilize, I think regular analgesia is better than PR analgesia in that setting. But Jackie, I'm sure will comment as well.
Yeah, I agree, Hannah. So I like the concept that they only need them for a few days, but people, particularly with those long IM nails, the idea that you can just have 3 days of Targin and then it suddenly disappears off the chart, it's not the reality when you're trying to get them up and mobilizing them off the forearm support frame onto the relator frame. I find they're on them for certainly much longer than 3 days, and many of them go home on opiates, and they really do need a plan to have their opiate dose reduced and subsequently stopped in the community. We'll
move on to our last topic now on bone protection. The question starts off with osteoporosis treatment at day 3 post-operatively. Would you recommend that that's a good time to start medication? The day 3 is entirely arbitrary. Yeah. 50% of these people have already fractured. I would have argued that the time to start their treatment for osteoporosis was before they had their hip fracture, whereas we're dealing with the consequences of not having treated osteoporosis in years gone by when they've already had a low trauma fracture. I'll start treatment for osteoporosis as soon as I am able, which usually means that I've got a vitamin D level back that tells me that the vitamin D replete, that the calcium levels are normal, and for those that I'm doing a secondary osteoporosis screening, that's all in the pipeline. But the number of days is entirely arbitrary. But the sooner you start it, the sooner you will start to reap the benefits. Jackie, with your secondary osteoporosis screen, can you just talk us through what's included in that? So for most people, they're just starting on treatment for osteoporosis, you want to look for other causes of osteoporosis. So you're looking for things like multiple myeloma, significant, maybe parathyroid disease. So the blood tests that we tend to do are full blood count, EUCs, liver function tests, CMP, thyroid function test, vitamin D, ESR, urine for Bence-Jones protein, and serum electrophoresis. I've probably forgotten something. Fair enough.
But I
It's a
think,
big
Neve,
list.
again, important reserve is to decide what doing as a routine for everyone and what they're doing in selected cases, and then stick with it. And agree completely with Jackie. I think it's the point of discharge is generally when you have to make sure that there is osteoporosis treatment on the script. And we've made a decision that we don't actually give the denosumab injection if people are going to get it. They go to their GP and get it, because we hope then it's more likely that the GP will add the recall to their system and they'll get their second injection as well. So we tell people, we give them the medication, we say go and arrange for your GP to give it when you're walking well enough, but the important thing is it's on that discharge script. I think it is really important that Ian comment on this, because there's orthopedic surgeons around who still have views on this, so it would be really good to have Ian comment.
Yeah, orthopedic surgeons are scared of drugs. Other people are scared of surgery. There's actually two drugs. So there's a thing in orthopedics that non-steroidal drugs, for example, will slow down healing of fractures and incorporation. There's really not any good evidence for that at all, and the known downsides of the alternatives mean that that's something that really shouldn't be considered. So I was just going to raise that before. But yeah, also with like anti-resorptive therapy and things like that, there's a fear that this will, delay the bone healing process. But again, there's not much evidence for that. And so where we are, we don't take that into consideration. So it is something we have to get over. We act a lot on theory and not on fact. But I was just thinking, one of the Hannah said that they give a prescription and they don't actually give the drugs in hospital. That's interesting, because a lot of hospitals do that because of the cost. And they want to put the cost onto the sort of PBS system rather than have it show up in the hospital system. But I don't know how often that's a problem.
I think that is true too, Ian, but I think the most important thing is that denosumab is one of those medications where you have to keep taking it. Otherwise, you could be doing more harm. So, the logic is that if you go to your local pharmacy and your local GP to get that medication and that injection, then you're more likely to get the recall for the next 6-month one, because it's an intermittent injection. It's one of those things that's quite easy to drop off.
Yeah.
And we want people to stick to them, because otherwise it can increase their risk of vertebral fractures.
Very interesting point, Hannah. It'd be interesting to see whether your strategy longer term is effective, because I would argue that by getting them started on treatment in hospital, at least you've actually got the treatment started. And there's lots of evidence that just sending GPs information or giving patients information leaflets leads to nothing. So it would be interesting to look, maybe using PBS data 18 months down the track, which strategy is more likely to be effective.
Interestingly, we've got some data. We did just do an audit on 100 patients and showed that if we'd added osteoporosis as a diagnosis in our discharge summary, that helped, as did very specific instructions in the discharge summary, which we're again trying to consistently add. So I think some of those things where you're just very consistent, and just to be clear, we actually give them the medication. We just say, go to your GP to actually get the injection. So it is just about that worry about them not getting the recall added. But yeah, we'll talk about it. We're going to put it as a poster at the FFN meeting. But I think there are things that you can do that, if you consistently write the same things in discharge summaries, do increase the chance of GPs regularly adding them into their systems.
I had a few questions about dental reviews and post-operative delirium delaying bone protection agents being started.
Delirium wouldn't faze me. Dental reviews, we just give the same advice that's in the GP guideline. If you need a dental work doing, great, go and get that done first. But otherwise, regular dental reviews and have the injection. There's a lot of dentists out there telling people about not taking their osteoporosis medication, and it is worth definitely talking about it with patients. Otherwise, they go and see a dentist and get scared. So I think it is definitely worth talking about with patients and their families. But there is a lot of discussion going on in the dental community about this, which, because they see, it's like all of us, when we see a complication, so when we see an atraumatic femoral fracture, we immediately think, oh, we're harming people. But then you put it back in perspective, because you're seeing a lot of people who don't have any problems, and who actually, we see way more osteoporotic fractures than we do atypical femoral fractures. I think the dentists who see someone with a severe complication, which is very distressing for that individual, don't necessarily have the perspective to see how many people are actually on these medication, and therefore this is a very rare side effect. So it's like all of us, we can overinflate the risk of something, but the data is very clear that you're better off having the medication.
And on the topic of someone having a hip fracture when they're already on like a bisphosphonate, what's the next option for refracture prevention?
So I guess the obvious one, if you're on a bisphosphonate and you fracture on a bisphosphonate, most of us would move somebody across onto Prolia or denosumab, and they're the bisphosphonates and denosumab, the two agents predominantly used in Australia. Raloxifene, there's no evidence for raloxifene in relation to hip fracture prevention, and we're talking about a hip fracture population. There are a couple of other agents that are available in this country. So we've got teriparatide, so synthetic parathyroid hormone, and then more recently the TGA approved romosozumab, which will be called Evenity. But there are very strict criteria for moving on to one of those agents. They're fairly expensive. They're very definitely second line. You have to fill full criteria. So your BMD has to be less than 3. You have to have at least 2 low trauma fractures. And one of those low trauma fractures has to have occurred after you have been on an alternative treatment for at least 12 months. And you can only have either teriparatide or romosozumab. Both of them are administered subcutaneously. And so you can only ever have one course of them in your entire life. So on the whole, it's a bisphosphonate across to Prolia, or sometimes the other way. The second line romosozumab and teriparatide we use less often. I personally tend to refer to an endocrinologist if I'm thinking second line treatments.
What guideline would you recommend for osteoporosis management?
RACP GP guideline is probably the best one. It was the second edition was updated in 2017. It's due to be updated again. They tend to do that in partnership with what was previously Osteoporosis Australia, which is now Healthy Bones Australia. That's probably the best document to follow. There's a very nice flow diagram, takes you through fracture and bone mineral density and when to do DEXAs, etc., and then treatment options. That's probably the best one that's available in Australia.
And the last question we have is on fracture liaison services or fracture and falls prevention services. Where do you go to find funding for these sorts of services?
Hospital dependent. If they're based in the hospital, otherwise they can be sort of district dependent, and it's also going to be state dependent. So, for example, in New South Wales, having a fracture liaison service is deemed part of, I've forgotten what they categorize it as, Jackie, but it's something that all hospitals should do. Now, the New South Wales Health have said that without providing funding. They've just said that this is something that all hospitals should do. So, hospitals are doing it, but they're complaining because that hasn't come with any funding. They've just been told they need to do it, but it's going to vary.
It's an interesting model, though, Ian. So you're right. So there was it was through Leading Better Value Care, and there is now an expectation that all local health districts have a fracture liaison service. But they're very clear that the way to cover your costs is you work within our existing financial frameworks, and it's through activity-based funding. So you have to generate activity, and the more activity you generate, the more costs you get back as a result. You have to work out where you can claim, and most of it's doctors seeing patients is where you generate your income. So that's the model that they're pushing. I haven't seen the economic evaluation of it, but that's very definitely what they're promoting, is you generate the activity. So we know the patients are out there. You generate the activity, you see the patients, there's an income associated with with that, then that covers your costs theoretically.
Niamh, I think we need to be challenged as well to do things more innovatively. I'm happy to share with you, to put on the website again, our local guidelines, which were adapted from the RACGP guidelines, but really target secondary fracture prevention in our older, frailer population. As Jackie said, there's a younger group of people who need it, endocrinology follow-up for that specialist follow-up long term. I think, Ian, we also need to work with orthopaedic surgeons more. We've been developing a pathway through our orthopaedic fracture clinic, actually, which doesn't require lots of extra resources, but has increased the number of people getting treated. And there's some evidence that we need orthopaedic surgeons on board with that, because if people fracture and don't get told by the surgeon who fixes their arm that they've got osteoporosis, then they're unlikely to believe anyone else. So I think we need to be challenged to do things more innovatively. And in Australia in particular, we are underutilizing our orthopedic surgeons in this space and need to work in partnership more to develop efficient pathways.
Yeah, thank you everyone for your time today. Greatly appreciated. And yeah, stay tuned for further podcasts and webinars coming up, answering more questions soon.